Hello, today my presentation is on Cusp Overlap and Commissural alignment. Here are my disclosures. So the factors affecting conduction disturbances after TAVR consists of non-modifiable factors such as advanced age and right bundle branch block. It's also depending on septal length and annular oversizing. However, one modifiable factor we can consider is implant depth. So how we measure septal length can be estimated as follows. There are many ways to do this. And what we do is using the coronal view, you go at the base of the aortic valve cusp to where the membrane septum is. And then this is where the myocardial origin. You can see that here and here. And this is the quickest way to estimate the membrane septal length. Now, the target implant depth, you look at the non-coronary cusp for the self-expanding valve. And of course, back then, the original core valve, the recommended depth was 6 to 8 millimeters. The evolute was 3 to 5 millimeters. And in 2023 now, there's a trend towards the higher, the better, as long as you can avoid a pop-out. So the evolute now, the recommended depth essentially 0 to 3. But now with evolute FX, I would say it's more like 3 millimeters. So here's an example back in 2015 where the older generation valves were available. So this patient you can see has extremely large annulus with a very large perimeter. At that time, it was not suitable for 29 sapien XT by area. And with 31 core valve, it was undersized by perimeter. And you can see that here it's a tri-leaflet calcified valve. And you can see the sizing chart for the core valve. We are certainly undersized based on this anatomy. So how do I implant an undersized TAVR valve? The answer at the time would have been to use a RAO Cusp Overlap view. This was the first paper that describes the Cusp Overlap view, published at the in 2018 after a few years of work already. And at that time, really, the concern was not so much about the pacemaker as actually trying to get an enforced view of the non-coronary cusp to enable higher valve implantation to seal against the annulus in the case of undersizing without device pop-up. So here's how it looked in the core valve classic deployment back then. You have the free cusp view. Then when the valve crosses the annulus, you take the parallax out. As a result of that, you're no longer coplanar and your right cusp rises higher. And when you flower the device, you can see that here it goes from the yellow dot to the red dot to make annular contact. And here's what it looks like afterwards. Now with Cusp Overlap view, you can see that here, by doing so, your flowering distance is reduced. Look at this here from yellow to the green/red dot. And so you make the annular contact much sooner so you can get to the 80% more quickly and try to be able to deploy as symmetric a fashion as possible. And you can see that here, comparing the Cusp Overlap view and the free cusp, you can see the frame distance is shorter because this is overlaying more in the short axis of the aortic valve annulus. And here's an example how it looks. So you can see this is the operator view here as free cusp view. And you have the evolute position as in this essence, lodged between the non and the right cusp. So your flowering distance is shown here with this dotted arrow, as you've seen here, and as you've seen here on fluoroscopy. But the actual flowering distance is this way, across to the base of the left cusp. You can see the longer distance, and the catheter, of course, is less center because you have to go from here on the left side of the green to the right. Now, the Cusp Overlap view, you can see that here the catheter appears more center, the flowering distance is shorter, and so you have make the annular contact faster. And here's how it looks like the true depth of the Cusp Overlap view. It separates away from the membrane septum, highlighted in blue here, and so the non-cusp is sprayed more open. As you go in the free cusp view and the LAO view, you can see the non-cusp is now much more wider, so it's harder to gauge the true depth because it flattens and overlaps with the right coronary cusp. We have seen that there's been data showing that Cusp Overlap reduces pacemaker rate with the self-expanding valve, as most recently with the optimized pros cohort that's been published. So how we do Cusp overlap view without the CT is relatively easy. You place a pigtail or J-wire on the right cusp, and you place a similar catheter or J-wire at the bottom of the left cusp. And you get the free cusp view here, and you just overlay the wire and the pigtail in this case like this, and you get your Cusp overlap view. So in patients with CKD who can only get limited contrast CT or non-contrast CT, this is a very helpful technique to get the final Cusp overlap view. So here's an example of a case of a patient who would fit a 26 alveolar valve with a smaller LVOT. And you can see that with this combination, it can have a higher risk of pop-out, especially valve is implanted high. So what we see here, you can look is the free cusp view, and we're now able to rotate the C-arm angle to the aerial caudal projection and get the Cusp overlap view. And the case involves a 79-year-old female with multiple comorbidities of a low flow, low gradient severe AS with normal ejection fraction, deemed by heart team as a high surgical risk. And you can see that here the annular perimeter is 18.5% oversized and more oversized with a smaller LVOT. And you can see that here with large aortic root, no issue coronary obstruction, tri-leaflet aortic valve with a horizontal root of 65 degrees and a bit of tortuosity and calcification in the access. There is no significant aortic valve angulation. However, you can see there was a calcified ascending aorta. So you can see that this patient would fit a 26 alveolar FX, right transfemoral approach, because the small LVOT and horizontal aorta, we would pre-dilate with a 20 millimeter balloon, and we insert the flush port at 3 o'clock and deploy the valve at Cusp overlap view, aiming for 3 millimeter depth because the septal length is less than 5. So here's how it works. You can see that the free cusp view and then the Cusp overlap view as I have described before. And we pre-dilatate. You can see that here our initial implant point of the alveolar FX is actually inflow to the base of the NCC. And you let the valve flower under control pacing, and you're aiming for 2 of the 3 dots at or below the annulus. Now, in this case, you can see we swing now to the LAO view to make sure we have not missed the left. But you can see the right certainly is quite high, almost at 0. And so we might be concerned about pop-out in the setting of a smaller LVOT. Now, rather than recapture, you can actually push the catheter more to the outer curve and actually try to gain some depth. You can see that here, certainly now, the depth is not 0 or 1, but rather around 2 to 3 millimeters with the dot marker here at the base of the NCC. And so you can see the left cusp is still good, around 1 millimeter. And as a result of this, we feel that this will have a low risk of pop-out as long as we release the valve safely and methodically. And so we do not need to recapture this valve. You can see after we release now, the depth is around 1 millimeter here and about 3 millimeter here. And the Cusp overlap view, you can clearly see that to be the case. And so we have a very satisfactory implant without a pop-out risk using this push technique. And on the fluoro CT core registration, you can see have excellent commissural alignment. So the patient had first PVL, low gradient as expected, or alveolar FX, no EKG changes, and the patient went home the next day. So in summary, with the Cusp overlap technique using alveolar FX, the depth markers are helpful during initial deployment to avoid implant the valve too high. So first step, you start the Cusp overlap view with the FX inflow at or just above the base of the pigtail of the NCC. Aim for 2 of the 3 dots at or below the annular plane at annular contact, especially when the inflow has parallax. If the 2 of the 3 dots are above the annulus, then your valve is too high and risk pop-out. This would be confirmed on the LAO view. So you swing the LAO view and line up the 3 dot markers to take out the parallax and assess the LCC depth. If the NCC depth there appears high, you should push the catheter forward to see if it go deeper on the NCC. And if it does move forward, the inflow is deeper than the NCC, then the risk of pop-out will be low. And then therefore, you don't need to recapture and can just release the FX valve using control pacing per standard practice. And this technique has really allowed us to reduce the risk of recapture and the need to do that, as even if the valve was implanted a little bit higher on the NCC. So 3 key steps in efficient FX deployment. Start with cusp overlap at the inflow FX and the frame, add or just above the pigtail at the NCC, and aim for 2 of the 3 dots added below the annular plane at contact, especially when the inflow is parallax. Swing to the LAO view, line up the 3 dots to take out the parallax, and do an injection to assess the LCC depth. And if the pleased result with both NCC and LCC depth, you release the FX per standard practice. Now, what about TAVR in SAF? The ideal view is really to minimize the parallax of both evolute delivery catheter at the inflow and the surgical valve. So any fluoroscopic view that can achieve this will work. Can be RAO, can be LAO cusp overlap view. And LAO cusp overlap view, however, is most useful to assess the left main flow at 80% deployment. So here are the 3 examples of evolute system to task in SAF to reduce the parallax of both surgical valve and the evolute system. As you can see that here with the mosaic valve and here with the Paramount 2700 valve. Now, cusp overlap view, of course, we know is also helpful in commissural alignment, especially with self-expanding valve. You'll see this paper published by the Denmark group showing how this is done. And even with SAPIEN 3, the Cleveland Clinic group has also demonstrated reduced pacemaker rate when you deploy the valve at an RAO caudal projection. And the Vancouver group has also shown that as well using the cusp overlap view. So in summary, the cusp overlap technique facilitates true depth assessment of valve deployment in TAVR, enables optimal implant depth, and minimize pacemaker risk. It really applicable to all self-expanding valve and maybe even balloon expandable valve. And so the natural fluoroscopic implant view to assess and achieve commissural alignment in TAVR as well. So next, I want to talk about commissural alignment. So what is commissural alignment? You can see the left side, the favorable alignment is basically the near complete overlap between the transcatheter valve commissure to the native valve commissure, such that you have a wide open amount of cells available to access the coronary. Versus here, you can see the commissural post faces one of the coronary, so that you have to go on either side of that to access the coronary, so it would be unfavorable alignment or total misalignment. And here's a standardized definition of commissural alignment. You can see here, perfect alignment with 0 to 15 degrees. 15 to 30 is mild, 30 to 45 is moderate, and finally 45 to 60 is severe misalignment. Now, why may commissural alignment be important in TAVR? First of all, it's still coronary access, especially in taller valves. It reduces the coronary obstruction in TAVR and SAF. Increases also the chance of redo-TAVR by reducing the risk of sinus sequestration on coronary obstruction. And of course, there might be a long-term impact on durability, and there's maybe some evidence now of increased Hall or gradient with misalignment. Leaflet modification, just as basilica, a shortcut, would not be feasible if you have a commissural post facing a coronary. And finally, certainly all the manufacturers now are focusing on this topic. And so we know that it's extremely important, not just to us, but to them as well. So here are the 6 areas that commissural alignment would be beneficial. As I mentioned before, you can read this at your own leisure. But really, one of the most important aspects is coronary artery disease in terms of management post-TAVR, because a lot of these patients, even intermediate and low risk, have some concomitant CAD, and they'll likely need coronary angiography or PCI in the future. Now, the reason why coronary access after TAVR can be challenging is because of one, most interventional cardiologists do not do TAVR, so they are not familiar with the devices themselves. Second, you have the variable aortic root anatomy. And third, you have multiple barriers facing the coronary arteries, such as the native aortic valve leaflet, the THV stent frame, and of course the THV commissure if you don't have alignment. And so the important aspect of this is that you can have a short balloon expandable valve, but if you have a bulky calcium and you have a short anatomy here, your ability to engage the left main selectively will also be difficult. Versus here, you have a self-expanding valve inside surgical valve. These valves are implant supraannular, So you can see there's a very low left main. So engaging both frame, the evolute frame down the low sinus height and the scientific junction to the left main will be potentially challenging. And in fact, if you look at the data out there, at least over 10% of the time and over for the balloon expandable and over 20% of the time of the self-expanding had a commissural post facing the coronary orifice. And so you can see that paper here looking at coronary access after TAVR also is driven by the commissural orientation. This paper published 5 years ago by our group looking at anatomic and device and procedural factors of both balloon expandable and self-expanding valve in terms of coronary access. And in fact, my colleague, Dr. Sharma and Dr. Kinney have developed and I have developed an app together on both Apple and Android platform. You can download for free, or you can go to this website and they'll teach you about different catheters to engage the coronary after TAVR, either commissural alignment or misalignment. So I encourage you to check this out. So you need to understand the aortic root anatomy and the TAVR device type to be able to determine about commissural alignment and coronary access. So the shorter frame valves, such as balloon expandable or mechanically expandable, are more relevant in terms of redo-TAVR, unless the stent frame goes above the STJ. However, the taller frame valves, such as the self-expanding valves, are relevant in both coronary access and redo-TAVR, especially with a supraannular valve. So you can see commissural alignment is important for coronary access for both therapies. And if you look at the commissural pose here of the different transcatheter valves, it's very important to note that if you have misalignment, this commissural pose is going to increase the barrier to reaccess because it represents a huge kind of a scaffold of a triangle. You can see the example here, looking at the right coronary. And you can see that here very clearly that with suboptimal alignment with the evolute valve, you have to go on either side of the cage of the cells to be able to engage the coronary on the red circles. And with optimal alignment, you can go directly above with lots of space, lots of cells available to the coronary artery, even if it shows that it's below the ceiling skirt. Now, in terms of TAVR sub, people say if you can do leaflet modification, you don't have to worry about commissural alignment. That is not true. You can see that here in these two examples, letter E, you can see the SAPIEN 3, the tab is still facing the left main, or the coronary rather, and you can see the letter G, the evolute valve here is positioned with the ceiling skirt and the leaf commissural skirt facing the split orifice of the surgical valve. Now, in terms of commissural alignment, it also matters in coronary access after TAVI and TAVI. So you can see if the first valve is a short valve and your second valve is a long one, then the commissural alignment of the second valve really matters because that will allow you to access the coronary. On the other hand, if you have a tall valve to start with and you've been put on a short valve, then you need to make sure the tall valve, the first valve, has good commissural alignment such that it would have easy coronary access, especially if a shorter valve is deployed inside. So this paper we published a couple recently on JACC intervention on redo-TAVR, and you can see that commissural alignment is extremely important to achieve to facilitate redo-TAVR. At the same time, it also improves redo-TAVR ability. How? You can see that the ceiling skirt, or the neo skirt rather, now reduces from the top of the frame, for example, with the SAPIEN 3 valve, to not only the inner skirt, because the leaflets would have been modified inside the open frame will be available for coronary access and redo-TAVR. You can see that the evolute here, it could be reduced by this much. Portico shown here, but it's actually navitor now, and then accurate neo 2 as well. And if you need to have more spray and more perfusion, you should definitely consider balloon-assisted basilica or modification, such that you have better room of margin for error. This paper we published 3 years ago on aligned TAVR, looking at different commercially available valves on the ability to align with the commissures. And you can see that with SAPIEN 3, unfortunately, despite crimping about different clock faces, we're not able to consistently achieve commissural alignment at either option. However, SAPIEN X4 has a central knob that allows you to actually turn the delivery catheter. You can see that here, such that the letter C can faces you directly, and you can relock this and then try to optimize and get your commissural alignment across the annulus so that when you deploy, your commissural orientation will be better. With Evolut system, the C-tab is located 90 degrees from the head marker. You can see the relationship here. So the ideal role is to have the head marker at the outer curve on an LAO projection. And this is how it works. You can see that with flush for 3 o'clock, your head marker will be outer curve at the descending aorta, and it continues to track at the outer curve. And when you cross to the annulus, when you rotate to the Cusp Overlap view, the head marker should be facing you directly most of the time. And you can see after release, the commissural alignment usually it faces the right side of the screen in the Cusp Overlap view. So this is the Evolut FX multi-center early in human LMR limited market release experience. You can see that here has different groups of patients, such as 4% bicuspid and 11% valve in valve. A third of them are low surgical risk, and you can see most of them constant sedation. 2/3 of them are done with inline sheath, and almost all of them have optimal marker deployment. And you can see that the implant depth is more symmetric than Pro Plus. You don't have a corbel dive or corbel swing anymore and become unpredictable in terms of final depth. This is quite predictable now versus initial implant. And you can see that here, commissural alignment, it's about 96.5%. So certainly very high in terms of a technique-driven deployment to achieve alignment. You can see also the 30-day heart outcomes are also very acceptable as well. Now, when we compare Evolut FX to Evolut Pro Plus, and it's a single center, you can see that here, the number of improvements such as commissural alignment, head marker and the outer curve is good, but also more importantly, the implant depth is much more symmetric versus before. And so as a result of that also, we have not needed to capture reposition compared to before. And you can see that it also improves coronary access, and shown by this beautiful article by Giuseppe Tarantini's group, showing that you can still have selective and semi-selective access if you have commissural alignment, which is important. Now, how do you identify these commissural posts? Each valve is different. You can see the C-tab on the Evolut. You see acroneal is right there, converging of the arches, and then the portico, now called navitor, has something similar as well. With the acroneal 2 commissural alignment, it's relatively straightforward. You can see it's 6 o'clock to start, and you get to the annular plane just above that before you cross into the annulus. And you look at where these wings are. If the wing is 2 to 1, then you rotate the delivery clockwise away from the operator, such as you have a one of these wings behind you. And if it's the opposite, then you swing the opposite way. So you always go in the turn direction of the tab that is only single in the cases. And so if you have 1, 1, 1, obviously, then you need to proceed to step 3. So step 3, what it does is that when you go to Cusp Overlap view, one of your tabs should be facing the right side to confirm optimal alignment. And if that's the case, then you just let go of the catheter and you then to reduce the tension, and you just start to deploy as standard practice with accurate neo2. Now, what about if the patient has eccentric coronary arteries or bicuspid valve that you might have some trade-off with your coronary overlapping with the commissural post? So what does this group describe was actually using what we call coronary alignment, essentially split the difference between the left main and the right coronary, kind of bisect the angles, and then you can see that here, that way you are not severely misaligned with either of the artery and also not one of the artery. And so how it works is that you go into the Cusp Overlap view, and you go more extreme areal caudal to be able to overlap the two cusps, the two coronary arteries together, and that's how you can get your viewing angle. So in summary, you can read this review paper at your leisure on how to achieve commissural alignment with various devices. So in summary, the coronary TAVR devices are not designed to achieve commissural alignment, but newer technologies and techniques are coming. But alignment does make lifetime management of these patients with AS and CAD potentially easier. There have now been technical modification using the Cusp Overlap view to improve self-expanding TAVR alignment. It works really well for Evolut and Anchor Neo 2, but not SAPIEN 3 or Navitor yet. You can see the flush port at 3 o'clock for Evolut and 6 o'clock for Neo2. However, what we need is the CT-based and patient-specific analysis that may improve commissural alignment in TAVR devices. Now, in certain situations with eccentric coronaries, coronary alignment would be helpful. However, this is well less than 5-6% of the time, and with the leveling is even lower. Prospective studies, however, is necessary to perform coronary access after TAVR, such as demonstrate that it's feasible and also efficacious. And of course, device manufacturers really need to design miles and delivery system to consistently achieve commissural alignment. Right now, it's still technique-driven improvement and achievement of alignment. We really need to have dedicated devices with the existing delivery system to be able to manually adjust and optimize the alignment of every single patient depending on the anatomy. So on that note, I'd like to thank you very much for your attention.